So in this recording, we are going to discuss a very important topic, and that is how our body adapts to low cardiac output. So low cardiac output could very quickly end with altered mental status. So these mechanisms are critical. So there are primarily two mechanisms, and one is baroreceptor reflex that acts very fast in minutes. And then we have another adaptation axis that involves renin-angiotensin-aldosterone system, and that takes a little longer. So we'll start with the baroreceptor reflex. So in our big vessels like aorta and carotid, we have baroreceptors that are bringing signals to the brain. So the baroreceptors are stretch receptors, and when there is a low output from the heart, uh, these receptors will be understretched, and the signal will travel through cranial nerve 10 from aortic arch and cranial nerve 9 from the carotid bodies to the medulla oblongata, where we have regulation of vital organs. And in the cardiovascular center, this information is processed. And when the signal is understretched, meaning low cardiac output, a sympathetic system will be activated. And so here you see the tract going from medulla to the butterfly to this intermediate horns in thoracolumbar area. And from there goes the preganglionic sympathetic nerve, and then it interrelates, and then from sympathetic ganglion arrives to the heart. So we have here signals going to sinoatrial node and atrioventricular node, and therefore, if the heart beats fast or faster, our cardiac output will be higher. Just for reminder, cardiac output equals stroke volume multiply heart rate. So here we are affecting the heart rate. Now, we see that some sympathetic nerves go also directly to the muscle of the heart, and they will stimulate it. So we will also have increased contractility. So this is a very important factor that affects the stroke volume. So on this picture is depicted how the sympathetic system affects sinoatrial node, the pacemaker of the heart. So you see here on the black, with the black pen, is marked the normal pacemaking activity. In case of SA node is about 70, in case of AV node about 40 beats per minute. And now when these centers get stimulus from the SA node, they will beat faster, and they will beat faster because this part, the slope, the spontaneous depolarization is going to be faster under the influence of sympathetic nerve. Now, we also said that the nerves go to the muscle directly, to the heart muscle. So on this graph, you see Starling law on the heart, which says that with increased venous return, there will be an increased cardiac output. But these curves may be different. So this picture here depicts increased contractility. So with the same venous return, same end-diastolic volume in the ventricle, the heart, because of stronger contraction, is going to eject higher stroke volume. So we discussed heart rate, and we discussed increased contractility that are compensating the lower cardiac output. Now, what was not shown in the picture here is that we have also sympathetic activation of adrenal gland that is releasing epinephrine from its medulla, and also that we have sympathetic nerves at lower level of the thoracolumbar area that go to arteries and veins in the body. So what's happening in the arteries and veins? So stimulation of veins by sympathetic system is going to increase venous return. So what is actually happening is that the veins are the thinner walled vessels than arteries, and about 2/3 of blood and most of the time are stored in veins. So when a increased sympathetic activity stimulates the nerves, these nerves cause vasoconstriction of the smooth muscle in the veins, and as the veins contract, they propel the blood going to the ventricles, to the atria and ventricles. So the sympathetic activation is going to increase venous return, which is another way of increasing the cardiac output. One more thing that is happening is the stimulation of arteries. And when there is low cardiac output, it is critical that the blood is used for the vital organs, which are brain, heart, and lungs. And instead that the blood is limited to areas like skin, gut, muscles. Right? So there will be vasoconstriction in that area and decreased blood flow of those less needed organs. Now, this activation of sympathetic system is happening within minutes, but it also leads to activation of the of another axis, and this is the renin-angiotensin-aldosterone system. We said that the sympathetic is going to decrease blood flow in not needed area, which includes abdominal cavity. And in abdominal cavity, we have kidneys. And when there is a decreased perfusion of kidneys, this is a stimulus for kidneys to release renin, specifically from an area called macula densa. Renin then starts a cascade that leads to formation of angiotensin II. First, it acts on liver to release the precursor, the angiotensinogen, which is a peptide, so several amino acids, and the renin then clips it, makes it angiotensin I, and as the angiotensin I goes through the lungs, it is clipped again and becomes angiotensin II. So these substances now created angiotensin II, which has two main properties. It is a potent vasoconstrictor, so it supports the sympathetic system in providing the blood flow mainly through the vital organs. And also it acts on adrenal gland and the cortex and releases from there the hormone aldosterone. And aldosterone is resorbing sodium in the kidneys. So sodium, if it increases the osmolarity, will also stimulate release of antidiuretic hormone from posterior pituitary. And the antidiuretic hormone especially will then act on kidneys to hold on free water. So this part, the effect of aldosterone on sodium and on resorption of water, is leading to increased extracellular fluid volume in the body. And as a result, if we have more fluid in the body, more blood is going to arrive to ventricles, and the end-diastolic volume increases. And as we showed before on the Starling law, the increased venous return is increasing stroke volume. So the sympathetic activation through baroreceptors and the renin-angiotensin-aldosterone system are the key compensation mechanisms to low cardiac output.